Okay, we should be live now. So welcome everyone. It is my pleasure today to host another Open Digital Health discussion. My name is Sebastian Potthoff. I'm a lecturer at Northumbria University and one of the directors of Open Digital Health. And today we have the pleasure to introduce Mr. Narayana Rao Sripada, who is the founder and CTO of Self-administered Technologies. Mr. Narayana Rao has 25 years of IT industry experience working with various tech companies in India, including Texas Instruments, Motorola, and Hewlett-Packard. He has technical and management expertise in software product development, testing and knowledge management, and expertise in enterprise and embedded domains. He's an accomplished leader in creating a culture of innovation while leading various teams, organizations at TI, Motorola, and HP. He is an inventor of 5 US, 1 Canadian, and 1 Indian patent. And I'm very excited to welcome him to these conversations. So far, our program has mainly been with other researchers and academics, so it's a really nice breath of fresh air to have somebody who's actually working in industry and from that perspective. So I will hand it over to Narayana Rao so that he can tell us about his journey about building the Swaasa AI Platform to identify underlying respiratory conditions. So over to you.
Thank you, Sebastian. Okay. So good morning, everyone, and good afternoon to some of the folks. So actually, I'm going to talk about our product called Swaasa. So Swaasa AI Platform is a kind of digital health tool for respiratory diseases. So Swaasa AI Platform primarily can be used as a screening tool and diagnostic aid in the assessment of respiratory diseases. So you can think of it as Google Photos for cough sounds. What we mean by that is, Swaasa can detect the respiratory diseases by analyzing the cough sounds. So it's like a point of contact software as a medical device for instant evaluation of respiratory health. So for example, the equivalent of home monitoring for blood glucose or a blood pressure, which we are all familiar with. So Swaasa is for respiratory health. So the platform do have APIs that can be integrated into any of the existing applications or clinical workflows very seamlessly. And we have done multiple validations, and almost we completed close to 7 clinical validations till date. So way back in 2017, we spent some time in understanding the problem. So what we came to know is that screening for respiratory diseases is an unmet need, primarily because the human expertise and the lab facilities. So essentially, spirometry is what is considered as the gold standard for screening respiratory diseases. So it's practically not possible to set up this pulmonary function test at a primary health centers. So that's really the unmet need. So any technology or a tool which can facilitate screening and identify whether the problem is attributed to the airways or the lung parenchyma will definitely be highly useful for the appropriate next intervention. So this is basically the kind of motivation behind us in developing this tool. And the problem as I mentioned, the unmet need we could understand based on a discussion we had with Dr. Anant Krishnan, who is actually a professor and head of the department for Center for Community Medicine at All India Institute of Medical Sciences. So to extend this further, these are the statistics globally for the respiratory diseases. So there are about 550 million people suffering with respiratory diseases, and 1 in 8 deaths are attributed to respiratory diseases, and there are about 7 million deaths caused by respiratory diseases. So the challenge is really the inability to screen, diagnose, and monitor lung health at scale and in real time. That's basically the biggest challenge, and Swaasa is actually addressing that challenge. So as I mentioned earlier, spirometry is considered as the standard for diagnosing or screening of respiratory problems. But that's being a hardware device, you require an equipment, and you also need some kind of a laboratory to set up that equipment. And then a technician is required to perform that equipment and to help patient conducting the test, performing the test. Obviously, you require an appointment to get the test done. So using Swaasa, we are unbinding all these constraints. So we are making Swaasa independent of location, independent of equipment, independent of technician, and you essentially don't require any appointment as such. So Swaasa is the product, and the company is called Salsit Technologies. So it is an outcome of more than 5+ years of research. So today we have a patented artificial intelligence platform for analyzing cough sounds. And currently we are authorized for use for conducting lung health assessment in India as a medical device. So we got significant support from Government of India, from Department of Biotechnology, and as well as Ministry of Electronics and Information Technology in developing this product. And this is our team. My colleague Venkat is playing the role of CEO, and myself, I'm the founder and CTO. And we have Manmohan, who is actually playing the role of Chief Information Officer. And then we have Dr. Raj Ranjan, who is a pulmonary and critical care specialist based in Philadelphia. And then Dr. Prashant Mahapatra, who is actually a professor computer science at University of California, Davis. And then Dr. Narendra Ahuja. These three are part of our advisory board. So, as I mentioned, primarily we analyze cough sounds to identify various respiratory conditions. So we will try to decode the unique signature or the unique acoustic pattern from the cough sound to identify pathologies like COVID, tuberculosis, asthma, COPD, interstitial lung disease, and bronchitis. So the underlying assumption is that cough do carry vital information about your respiratory system, and the cough receptors, which are actually located at different places in the respiratory system, when they get stimulated, the sound gets produced. And based on the location where the receptors are lying, the sound has unique properties, and that's exactly what we are trying to decode. So in addition to looking at the unique pattern, we can also derive some parametric information. Like, for example, we can identify the number of coughs in a given time frame, like wet cough or a dry cough. And having that information really helps to have a longitudinal view on how these coughs are varying over a period of time. So for example, if the trend is really increasing, then there's a cause of concern. So one will be able to have a longitudinal view about the patient lung health by using these parameters. So essentially, the technology what we have today is decoding the cough signature, extracting certain parameters which will have a clinical relevance, when you actually look at them over a period of time. So let me give you a little more, overview about, this cough signature. So here, as you can see, the cough signature seems to be different for various conditions. For example, when you take a normal cough, the glottal gets opened, and during the movement of glottal opening, your first expulsion comes out. So there is a first bout of cough, and as glottal slowly gets narrowed, you have the second expulsion. So essentially, you have about 2 sounds in a typical cough, in a typical normal cough. Okay, for example, when I am doing, so there are 2 bouts, right? But what happens is that when you have, a respiratory problem, your cough gets extended, or it can be folded multiple times. So for example, when there is a narrowed airway, what happens is that, the person has, he could breathe in enough air, but when he is breathing out, that's when the problem is. So there is an obstruction in the airways. So he's actually taking longer time to expel. So which essentially means the expulsion cycle is, is a bit longer, and also the cough is folded multiple times. So that's what is a typical condition when you have a narrowed airway. So essentially, what you see is, 2 or 3 cough bouts with multiple expulsions. Similarly, if you look at something like a widened airway with, when you have, say, for example, sputum or a mucus which gets accumulated in your airways, you see that the pattern again is different, where, you will be able to notice the presence of sputum, when that expulsion is happening. So that's again, you will be able to understand and decode, after recording the cough signature. But when you look at something like a restrictive condition, where the person is not able to breathe in, I mean, he has problem in really, breathing in. What happens is that obviously he does not have enough energy to expel, which essentially means the cough comes out to be more like a weak cough. Okay, but multiple repetitive bouts, because he does not have enough energy, he actually, coughs multiple times repetitively to expel the cough, which gets triggered, because of the problem. So that's like a case for the restrictive conditions, like, a scarred lungs. As you can see here, the person did not have a deep inhalation. So multiple repetitive, long and weak bouts is what you can notice. Similarly, if you look at something like a fluid-filled lungs, again here you have a slightly different condition, where the first expulsion comes out with a lot more energy, but again subsequent expulsions carry a very less amount of energy, and gradually they become more weaker and weaker. So the idea here is that, as I mentioned, based on where the cough receptors are, and when they get stimulated because of the abnormality in your lungs, the kind of sound what gets produced is different. And if there is a way we can learn and decode that sound, then we will be able to say that, yeah, maybe based on the cough, this person seems to have a problem with obstruction in the airways, or this person seems to have lung expansion kind of a problem, or this person is completely seems to be normal. Okay. So essentially, the idea is about decoding that particular signature. So going little more, into that, I mean, many of you, as I understand, you come with research background. As you can see here, the first row, the real cough signal, which is actually the audio file which got recorded. And in the second row, you can see that the way energy got distributed in the time domain. So, for example, if you look at disease conditions like interstitial lung disease or a COPD, and compare that with normal. As I mentioned earlier, normal, you typically have two bouts. The way energy varies in the time domain is different when compared with something like an interstitial lung disease and a COPD, where you have multiple repetitive cough bouts and with pauses in between. Similarly, when you look at something like an asthma, which is primarily an obstructive lung disorder, as I indicated earlier, the person has no problem in breathing in, but the problem is in the expulsion. So he has enough energy to expel, but because of the airway obstruction, he is taking it longer time. But because he is able to, put a good amount of pressure, the sound comes out to be more strong in nature. So that's why it is called a strong cough. And the amplitudes are kind of like more or less sustained, within the bout. That's what you see, for a condition like asthma. Whereas if you look at something like for pneumonia and all, as I indicated earlier, the first bout comes out very stronger, but then the subsequent bouts do not carry that same kind of the loudness, and you will see that a decreasing trend in the amplitude. So essentially, the way the energy gets varied in the time domain, there is a difference. That is one aspect of it. And then obviously the most interesting thing is how that energy is distributed in the frequency domain. I mean, for example, when you have normal, there is a significant discontinuity between the bouts, but then the energy do present more or less in the entire spectrum. The bandwidth is more, but it's not concentrated at one place. It is actually spread across the spectrum. But when you look at something like interstitial lung disease and COPD, you see that the energy is more and more concentrated in the lower frequency bands when compared with the high frequencies. But whereas something like for asthma, you see that it is actually somewhat more dominant in the medium frequency spectrum when compared with the the normal or the COPD kind of a condition. But whereas something like pneumonia and COVID, you see the energy is little more dominant even in the higher frequencies. Especially for COVID, the energy is a lot more dominant in the higher frequencies when compared with any other respiratory conditions. So again, the point is, essentially the location where the stimulation is happening and the path through which that signal is getting propagated, and the kind of pressure one is able to give while he is expelling is really giving a unique, is producing a unique sound, and that sound is kind of like distributed in a different way in the frequency spectrum. So that's essentially what will help you to decode the signature at the runtime. So putting it all together, I mean, basically this is what the product is. So we actually take cough sound as input. Along with cough sound, we also kind of like take information about St. George Respiratory Questionnaire. I mean, this is the symptoms information. It's only a subset is what we use, not the entire questionnaire. So we use the symptoms and as well as the cough sound, and that goes as an input to our Swaasa AI platform, which is actually primarily based on the machine learning technology. And what you see on the right side is what is the output of our device. So we provide, on the first box, as you can see, we provide primarily few recommendations. The first one is based on this input, we will try to identify whether there is any underlying respiratory problem or everything seems to be normal. Okay. If there is an underlying respiratory problem, then we will try to say whether this problem seems to be more attributed to the obstruction in the airways, or is it more like a lung expansion problem. So basically, this is called an obstructive lung disorder or a restrictive lung disorder. So we will try to say whether it is an obstructive or a restrictive pattern, and then we will also try to provide how severe it is. Is it like very much early in the stage, or it's medium high, that kind of a thing. Up to this, whatever output we provide is more or less functionally equivalent to an interpretation of spirometry. So spirometry, as I mentioned earlier, is considered as the standard test for identifying respiratory problems. So the technology what is used in spirometry is based on the flow characteristics, the airflow characteristics, like the amount of air you blow into a machine and you blow out of a machine. But whereas in our case, we are providing same output, but using the cough sound characteristics. So up to that point, we are functionally equivalent to the spirometry. So that's why we call Swaasa is actually a substitute to spirometer. In addition to that, we also provide additional functionality, like for example, based on the cough, can we say that maybe there is a likely presence of COVID? I mean, either the answer can be yes or no, or it can be inconclusive. I mean, basically, if we are not able to say with certain confidence that it is COVID or not COVID, then we will say it is inconclusive. Similarly, for tuberculosis, based on the cough sound and the symptoms information, can we say that maybe there is a likely presence of tuberculosis? Yes, no, or inconclusive. So this is the output, as you can see on the first box, and in the second box is more like quantitative data. Like for example, we extract total number of coughs in the recording. What we did. Typically, we do cough recording for about 10 to 15 seconds. Okay, so the idea is that in 10 to 15 seconds, a person will be able to do at least 3 to 4 expulsions, and 3 to 4 expulsions, recording cough from those expulsions, we will be able to extract good amount of information and provide whatever the output as I'm talking about here. So within that record, like what that 10 to 15 second record, we will also extract how many coughs are there, and how many of them are really wet coughs and how many of them are dry cough. So as I mentioned earlier, this will help to have a longitudinal view of the patient's lung health. And then we also calculate proprietary index values, lung health index. So essentially, this is the value varies from 1 to 10. 1 means that based on the analysis what we have done, the lung seems to be normal. If it is 10, then obviously there seems to be an abnormality. Again, that score can be divided into multiple zones. Say for example, 1 to 3 you can consider as a low risk zone. 4 to 6 you can consider as a medium risk zone, and 7 to 10 you can think about as a high risk zone kind of a thing. So that's a generic lung health reading, and we also provide other parameters like COVID risk score and TB risk score. Essentially, again, the COVID risk score is a combination of cough analysis and the symptoms as defined by World Health Organization. So basically, it is based on a weightage of symptoms and as well as the cough analysis. We will try to provide a risk score. in the scale of 1 to 10. So if it is again, like, if it is in the low risk area, then yes, there is nothing to be worried about the COVID. But if it is on the high risk, there is a chance that, the patient might have, COVID, and it is advisable to go and get, RT-PCR done, or maybe meet doctor and so on kind of it. So that is about the quantitative data. And of course, people, this is a new technology. As people start understanding it and start using it, they may also be able to kind of like look at how energy is varying, and how the energy is spread in the frequency domain. So we will be able to provide the energy contour plots or the spectrograms as required, as an additional data. So as on today, the capability what we have are all listed on the right side. So the ability to identify respiratory problem, and identifying the kind of pattern it is and its severity, and also detecting likely presence of COVID and tuberculosis. That functionality we already have. We completed multiple validations, to claim this functionality, and then what you see on the bottom, to identify the conditions like COPD, bronchitis, asthma, interstitial lung disease. The validation is in progress, and once that validation gets completed, we will also start claiming about the likely presence of these disease conditions. So as I mentioned, in addition to providing the output which is equivalent to the spirometry, and identifying whether the COVID likely is yes or no, the information like wet cough count, dry cough count will be very highly beneficial to have a temporal view. For example, in this case, you can see that how wet cough is varying, be it in the morning, afternoon, evening, and night. Similarly, how dry cough is varying, in the afternoon, morning, evening, and the night. So when we see that these coughs are crossing a certain threshold, again, that threshold is something you will be able to learn based on the data what you have. You can actually generate triggers saying that the cough seems to be increasing. Which essentially means some kind of an attention is required to take care of the situation. So different kind of alerts can be generated based on this. That's what I'm trying to say. So as I mentioned, we have multiple validations to support the technology what we have developed. So we completed our first clinical validation at Apollo Research and Innovation in Hyderabad. Primarily, the objective of that validation was to do a correlation with clinical test and diagnosis. The clinical test was in particular the spirometry. Okay, and then we completed COVID-19 cough sound analysis using our platform at Andhra Medical College, Visakhapatnam. And then one large-scale clinical validation is in progress at Christian Medical College, Vellore. And then we also completed very recently, as I mentioned, detecting likely presence of COVID and likely presence of tuberculosis. Again, the line items 5 and 6. These two validations we completed at Visakhapatnam, Andhra Medical College. And in addition to that, the platform also tried for lung health assessment in a primary health setting. Basically, generally what happens is that most of the time your clinical validations happen at a tertiary care hospital. But then obviously, if the device is can be used for screening and prioritization at primary health setting, then the effectiveness of that need to be evaluated over there. So we completed evaluation of our platform for lung health assessment in a primary health setting. That's what line item number 4. And again, one more validation similarly at a primary health setting is in progress at All India Institute of Medical Sciences, Delhi. So these are the different validations which we have completed at various places in India. And till date, primarily all our validations are in India. But now we have partners. We are actually planning to do validations and deployments outside of India, including in South Africa, Indonesia, and Australia. So just to kind of like give you, an idea about the different kind of validations we did and the kind of results what we have. The first validation, as I mentioned, the objective was to analyze the cough sound characteristics and establish the correlation with the clinical test PFT and then the clinical diagnosis. So we conducted this validation at Apollo Research and Innovation. So as part of this validation, we have recruited 240 subjects who are healthy and about 275 subjects who have various respiratory problems, and we did multiple cough recordings from them. And the data does cover a good distribution of various respiratory conditions like asthma. We have about 23%, bronchitis 19%, and so on. And it actually includes both patients who are hospitalized inpatient and as well as outpatients, and more or less equal gender distribution. But when it comes to age, primarily our device is targeted for 18 years and above. So it is not for below 18 years. And the entire data is annotated by the principal investigator, but the result of Swaasa is blinded to him, so he does not know the output of Swaasa. But then later, the statistician compared the results of the physician based on the diagnosis versus the output from Swaasa. So as you can see here, in terms of identifying the underlying respiratory problem, we have achieved an accuracy of 94% with 96% sensitivity and 91% specificity. Similarly, in terms of identifying the underlying pattern, we have an accuracy of 87% with the sensitivities and specificities in the range of 85 to 90%, as you can see. So, and in terms of identifying the pattern severity, we have about 92.14% accuracy. So we also did, repeatability testing, which is again like a very important aspect. So essentially, assuming that the physiological condition of the patient is same, if you do a cough sound collection, almost at the same time on the same day, versus on a different day, do you see that the consistency in the pattern, and are you able to consistently identify the underlying problem? So as you can see here, in all 4 cases, we are able to more or less the pattern seems to be very consistent, and in this case, it turned out to be a restrictive lung disorder. So that's what we could identify. That is actually an interstitial lung disease. So similarly, we did a clinical validation at Andhra Medical College for identifying the likely presence of COVID. Again, for this particular study, we have recruited patients who are actually tested positive with COVID, and similarly people who are tested negative with COVID. And then again, as you can see here, basically we have done this particular validation in 3 phases. The first phase is more about collecting data and building our model and establishing a technical validation or a laboratory validation, what we call it as. And once that is done, then really doing clinical validation in a tertiary setting. So the derivation study is about the laboratory performance. For example, as you can see, in a laboratory setting, we have an accuracy of 96% with about 95% sensitivity and 95% specificity. After that, when we subjected the device for validation in a clinical setting in a tertiary care level, we have about 95%, 76% accuracy with 95% sensitivity and 74% specificity. Again, as I mentioned, primarily we are using this device for screening and prioritizing. So you definitely need to be more sensitive. The device need to be more sensitive. That's what we could actually achieve for COVID. Similarly, we did validation for TB. Again, same setting, but only thing is it's a different hospital. It's a chest hospital. So where we recruited subjects, who are having positive TB, who are tested positive TB, and who are negative TB. And as you can see again, basically when it comes to accuracies at derivation level and validation level, at derivation we are 85% accurate with 87% sensitivity and about 79% specificity. And when it comes to the real validation for TB, when we did the validation, our device turned out to be more specific when compared with the sensitivity. But we are now optimized this, and we further tuned our models to be more sensitive by compromising a bit on the specificity. And because this is needed, because we are positioning our technology as a screening and prioritization tool. So in addition to that, we also did one validation at a rural health center. This is really because the technology is primarily targeted for rural and remote population. I mean, to address the challenges in the public health. So what we did is, we actually did one validation at a rural health center in connected to Andhra Medical College. So the way the validation was done was, in the month of January and February this year, when COVID Omicron was at peak. Basically, we have screened about 180 patients who visited the primary health center. And using our Swaasa, we have identified about 85 of them are likely to have COVID. And then those 85 are further really subjected for the RT-PCR testing. And out of 85, 62 turned out to be the really positive cases. So the positive predicate what we have is about 75%. So taking that into consideration, for example, out of 183, we could identify 85 of them as COVID, as positive, which means that for the remaining 98, there is no need for you to perform the RT-PCR testing. Am I right? So essentially, that is the kind of saving what you can have, when you have a technology like this, which can be used to really identify people who need to be considered for the actual diagnosis testing. So, that gives you some kind of an advantage in terms of the cost. And then obviously, when compared with any of the existing techniques like RT-PCR, or CT scan or anything of that sort, the time it requires to identify to get the test done is very, very negligible. Like we will be able to provide output within few seconds after the cough sound gets collected. Within 15 seconds, we'll be able to provide an output telling whether there is a likely presence of COVID or not. So compared to any other technology, we are much faster. So there is significant amount of time saving as well. So there is a cost saving and as well as time saving from the perspective of using these kind of technologies for screening and prioritization. Yeah, I mean, we have a granted patent in India, and we have multiple patents based on that in various regions across the globe. And we have a couple of publications, and the first one is in the medical journal, Information in Medicine Unlocked, based on our first clinical validation. And recently, our paper also got selected for the Union Conference, the abstract. I mean, basically for the Union Conference abstract, which is in November. Our COVID study methodology got selected. So we'll be doing a presentation around November timeframe. So yeah, we have few customers in India, but more importantly, these are our various partners. As I mentioned, primarily we got support from government in India in building the technology. On the academic front, we have partnerships with the All India Institute of Medical Sciences, Andhra Medical College, various other colleges, even University of California, as I mentioned earlier. So these are our partners outside of India as well. So the conclusion is that if we look at the pandemic situation, diseases like COVID, or even otherwise, the most concerned disease, the tuberculosis. So essentially the humanity's fight against these diseases, considering that, the results of Swaasa definitely provide an opportunity to frequently screen for cases spread across the remote areas and reduce the burden of cost and time on the public health infrastructure. So especially for the low and middle income countries, this implementation really opens doors to fight and eradicate the TB and COVID, especially at scale, because the technology is really capable of scaling. We can even do 500 million assessments per day. So to summarize all that, in one slide, this is all what what it is all about. Swaasa is all about. So basically, we don't require any consumables or the equipment. It's just a mobile device which can be used to collect the cough sound. And of course, there is also a provision wherein, like, we can send an assessment link to the patient's mobile. So he need not even download the application. He can actually open the link in the mobile browser and then give the cough recording there. So all that one requires is a smartphone, for him to do the recording of the cough and give information about the symptoms. So it can be done anywhere, because we don't have any dependency on the infrastructure and laboratory setup and so on. From anywhere the assessment can be done, and obviously anyone can do it. Someone sitting at home can also do it, or a health practitioner in a public health center can do the assessment, or a doctor sitting in a hospital can also do the assessment. And one thing which I wanted to kind of like say, right now, even though the assessment can be done at home and by any person, but the report, the whatever we provide, that will be interpreted by a doctor, and the patient has to reach out to the doctor, for whatever be the next, the next step. The report is not directly meant for any kind of a treatment or any kind of whatever an action to be taken by the patient directly. It is actually to a doctor in aiding in diagnosis. So that's basically one of the important thing, because the safety and the safety of the patient is really very important thing, and definitely based on our report. And one should not be taking any kind of unnecessary steps, like taking a medication kind of a thing and all. So that's why it is not meant for direct consumption by the consumer, but the report is available to the doctor for him to do whatever be the next step. Okay, but of course patient and doctor can be completely asynchronous. I mean, patient can be sitting at home and doctor can be at his office. And the patient can do the assessment and the result is available to the doctor. So that's what we mean by anyone can do the assessment and anywhere. Similarly, as I mentioned earlier, the time what we take in analyzing the cough and providing a result, it's like in about 10 seconds we will provide the result, and it is very inexpensive compared with any of the existing methods which are used for doing lung health assessment. And obviously the major advantage what the technology can bring in is we can really reach scale. I mean, we can do assessments on a larger volumes. We can even do in the scale of 500 million assessments per day if required. So that's basically essentially the summary of the technology what we have, Swaasa. So to screen, diagnose, and monitor lung health at scale in real time, remotely, and asynchronously. That's all what I have, and I'm actually open for any kind of comments, questions.
Thank you very much, Narayana. It was a really nice presentation. Really great to see about all the development work that has gone into this technology, and very impressive indeed to see what this technology is capable of, to produce at a scale. So I'd be very happy. I don't know if Jay has any questions. I have a few questions as well.
Sure.
I'd be happy to take them now.
Yeah.
Yeah, really interesting. That was great. Yeah, I don't have too many questions. I had a question and then you answered it on the next slide, so it was quite good. But I did the slide where you were talking about the accuracy percentages. So just say, I think it was roughly 94% accuracy. How does that compare with a clinician?
Yeah, I mean, those are compared with the, for example, just give me a second.
Like I imagine it would be significantly higher.
Yeah, 1 minute. I'm just flashing my slide.
Yeah, no worries.
Yeah, I did stop. Yeah, can you see my slide?
Yeah.
Yeah. So, for example, here when it comes to TB, the way accuracy is is measured is there are two parameters, two comparison points. One is the diagnosis from the clinician, and another is the diagnosis from the Swaasa. So, for example, when we say our accuracy is, for example, our accuracy is 86%. Which means that 87%, which means that 87% we could match with what clinician has mentioned. Now, clinician diagnosis we will consider as a ground truth because he has done whatever is required in terms of the investigation, be it CBNAT testing or X-ray, whatever it may be, to arrive at that particular patient is actually positive TB or not positive TB. Okay, so that way clinician diagnosis is ground truth for us. So the comparison is against that.
I see. Yeah, okay. Wow, that's great.
Yeah.
Are there any respiratory diseases that are particularly easy to detect in comparison to others? Are there specific cough sounds that stand out more easily? Correct.
Yeah, yes. That's a very, very good question. I mean, basically, as I mentioned earlier, for disease conditions like interstitial lung disease and COPD, we could consistently observe there is some kind of a uniformity in the pattern. Because for example, COPD is a very kind of like it is because of your dynamic airway collapse. What happens is that when a person does the cough, he actually does do take multiple pauses and give more and more number of bouts within a respiratory cycle. Am I right? So that way, like you see some kind of a repetitive energetic pattern with in between with some pauses, as I mentioned. So very unique about the COPD, and more importantly, as I did indicate earlier, COPD seems to be more dominant in the low frequency spectrum when compared with the other disease conditions. So that way, yes, for certain disease conditions, the signature seems to be, I mean, you will be able to decode signature with a lot more ease, but there are few disease conditions where the overlap seems to be quite high. I mean, for example, pneumonia and COVID, maybe the overlap is quite high. To really differentiate between them, you need lot more data sets, and you need to get into little more deeper in terms of latent features and so on kind of a thing. But you are right. I mean, there are certain diseases it is easy. Certain diseases you require more training and maybe hierarchical networks and so on kind of.
And how is it? Because you were saying, okay, it takes 10 seconds to actually give an initial sort of screening and give like an initial sort of diagnosis. Does the accuracy improve if you are able to take multiple readings from the same patient across the day or across multiple days? Is there more in-depth screening available?
Yeah, so I mean, see, there is some kind of a scientific thought behind this. So essentially, the thought is that when you ask a patient to cough, okay, so we are asking a voluntary cough. Am I right? When he is giving that cough, within that 10 seconds, whatever we are asking him to cough, if there is a problem in the respiratory system, the receptors should get stimulated. Okay, so once they get stimulated, then definitely 10-second cough is good enough for you to really understand the problem and kind of identify that is related to that. Okay, so that way, for example, as part of our validations, we do record multiple recordings, like by giving 5-minute or 10-minute time between the two recordings, but we will do consecutive recordings, but we are able to see consistent output more or less across these recordings. Okay, but the other point what you are mentioning about is the count, for example, the cough count, the number of coughs which you could detect in the given recording will vary. For example, if a person is having asthma, then maybe he should have more and more cough in the morning when compared with maybe in the day during the rest of the day. So that kind of an observation also we are able to see. So to answer your question, we strongly believe 10-second cough is good enough for us to give the initial problem about the underlying respiratory problem.
Yeah, that's very clear.
Yeah.
Jay, did you have any other questions? Otherwise, I'll just continue.
I know this for me.
Okay. I was just wondering, because you were saying that the report that is generated is something that will be interpreted together with a clinician who will sort of make sense of the data that comes out of your report. Is any clinician able to interpret that data, or do they need some special training to understand?
No, we don't require. No, not much training is required. I mean, it's all about for example, that report essentially contains the information what I mentioned here. So the report talks about whether based on the cough we are able to identify whether an obstructive lung disorder or a restrictive lung disorder, and whether we can say that there seems to be like a COVID or a tuberculosis kind of a thing. Am I right? So this is the report what we provide to the doctor. So in addition to that, as I mentioned, the count variations. I mean, he will be able to see in a dashboard how the count is varying. Say, for example, if a patient has done assessments, more than one assessment, okay, so he will be able to understand the variation in the cough count. That's also doctor will be able to see. So I don't think there's a lot of training is required. It is self-explanatory, and many people generally, they are familiar with the cough sound and the kind of information, especially doctors, the kind of information what it carries. So only thing is that till date, they used cough more like a subjective assessment, but now what we are saying is it can be used for objective analysis. So essentially that way. But the reason why we are not providing a lot of information to the patient is we don't want patient to get panic. So and as I mentioned, the side effects of giving a lot of information to patient is it can be sometimes not what we expect.
Yeah, so it's the process driven by the practitioner.
Yeah, and also from a regulatory perspective, so we are positioning that this is an aid in diagnosis. So that's why it should be more helpful to the clinician.
Maybe to finish off with a more general question, because there in our audience a lot of people out there who are also developing and hoping to probably patent and commercialize their digital tools. Now your solution obviously it's a result of a great collaboration with various stakeholders and experts, going through various rounds of validation. You've managed to successfully get governmental and other funding to keep this going and actually develop it into something that can be rolled out at a scale. I was just wondering if you could, give some sort of reflections and perhaps even tips on how to successfully collaborate with all of these different people.
So that's again, like, yeah, thanks for that question. So I'll definitely be able to share my experiences. So, essentially, see, when I started on this particular problem, I was an external advisor, for a project called acoustic signal analysis for healthcare. Okay. So, when the researchers were identifying, various acoustic signals and the kind of information they carry about the health of the person, we came across few articles which did mention about cough, and then relative to other signals, the research on the cough happened to be kind of like in the initial stages. Then we felt, why don't we focus on that and see whether we can actually get something promising out of that. But one first thing what you need to do is that whenever you are looking at these kind of research areas, obviously, yes, there is a starting point for you, but then you need to validate that immediately with the experts, whether, say, for example, in our case, I mean, does cough analysis will be accepted and can be used really to identify any kind of the underlying problems? Does that have any meaning? And if it has a meaning, does that carry a good amount of value? That kind of validation you need to do very upfront before you really go deeper into your research and your clinical validations and so on, kind of a thing. Because I myself, I'm an engineer. I mean, I don't have any background on the medical domain. But when we discussed about this cough, definitely there are people who believed in it, and there are people who said this is nonsense. I mean, this will not work. Now the question is, you need to talk to more and more people and kind of like arrive at some kind of an understanding, by taking into like what they think is going to work and where they think it may not work, kind of a thing. And then you need to kind of like take maybe the one which you will be able to prove as quickly as possible, and then go into the complex things little later slowly. So that way what happens is that the acceptance become a little more easier relatively. So that's the one of the exercise anyone need to do. One is that whatever the research which he is planning to start, is there a problem? Does that research is going to address some kind of a need? And the way in which you are planning to develop that research, will that really help in addressing that need? I mean, essentially, of course, initially you may assume that it will address the need, but essentially, while you are putting more and more effort, it becomes complicated. Then that's also a concern. Am I right? So, is it going to address the need in the way it's supposed to? That need to be validated. And another important thing is that you need to involve them in framing your the study objectives, and in kind of like saying that what is the value proposition of this. I mean, basically, how do you measure the value proposition of whatever the technology from the beginning itself? Okay, because if you do it everything on your own, then there is a chance that you may be going in a very blinded way with what you think is really the problem, but whereas the users are seeing it in a completely different way. So that's why you need to have their their involvement, and they should be the ones who will be defining the validation criteria, methodology, and so on, kind of a thing for your technology. Because at the end of the day, they are the people who are actually going to use it once it is really live, isn't it? That's one more aspect one need to factor. And the third one is, and the third one what I can see is that basically the kind of, you need to have a holistic view when it is a medical device. Am I right? So which category of medical device you are going to be? I mean, basically, see, for example, if your device, based on your device, if an immediate treatment can be done, then you are actually getting qualified as a high risk kind of a medical device. But whereas if it is helping in diagnosis or aiding in diagnosis, that is the case of our device, you are slightly low risk. So you need to understand which kind of category you fall into, and accordingly you need to devise your entire development plan and validations and so on, based on that. So if you don't have this, the categorization and the regulatory approvals what you need to have, then obviously you will get into trouble little later.
Really good. Thank you very much for sharing those lessons. I think that summarizes it really nicely, and I like how you emphasize also the importance of sense checking yourself and having those collaboration and experts who help you along the way, and also at the same time keeping the end product sort of in mind as you are planning around getting your device or tool authorized as a medical device. So that's really great. We come to an end here, Narayana. So thank you very much again for joining us for this conversation.
Thank you.
We will publicize this recording if that's okay with you, so that all of our subscribers and people following Open Digital Health can
also sure. We have no problem. And definitely,
if there's an email, if there are any, that's what I wanted to ask. If there are any resources like the publications that you were talking about, and any links that might be relevant, if you could send them to me via an email, then I will make sure that when we publicize the recording, I will also disseminate those resources.
Yeah, sure.
Perfect.
Sure, no problem.
Okay, then thank you very much again, and we'll speak soon. Thank you very much.
Sure.